Okay. One more session to go, guys. Great education, great morning and afternoon speakers. And what I thought I would do is do a question and answer session, so I would keep with the theme of the conference, a practical tutorial, ask you some practical questions. And some of it have been answered in the talk, some of it is old. And hopefully it will be a nice, easy way of rounding up, but it's a long session. We've got a lot of good feedback that patients wanted more of these. Did they hand out the audience response system? Okay. You will see an audience response system. We're going to try this out. And if it works well, then next year we will ask all speakers if they could have 5 questions or so that the audience could respond. So we'll see how this works. And before I start, first I would like to thank you all again for coming. I'd like to thank the hospital, Shasta Regional, for supporting us. I'd like to thank all of the vendors for supporting us. It wouldn't happen without the vendors. A few people I'd like to mention. First, Ted, AV guy, great job, nice effects. The hotel, the Gaia Hotel, were very good to us, and we appreciate all of their support. Rick Atkinson, who's really helped get a lot of great support for the conference from the vendors and so forth. Dave Nelson, who, every year I say I'm going to prepare this beforehand, and then the last minute I have to have him take a day off work to do all my slides for me. Dave, thanks for your help. And of course, our speakers, we appreciate them coming to Reading. And I haven't forgotten, a lot of my staff, Linda, Debbie, Jeff, all of my staff, Jeanette, everybody, who does such a great job. And of course, Sabina, who does everything and makes me look good. So thank you all. Now, what I wanted to do, I asked Richard to come up. If any of the cardiologists want to come up as well, they're welcome to come up, because this is question and answer. Everybody can give any input. Richard can tell me where I'm wrong. And so if anybody wishes, and I know he will, if anybody wishes to come up, but I seen Dr. Coronado around. Is he still around? Rob, why don't you come up and join us here at the podium? So what we'll do is we'll do this sort of as a panel, question and answer, and it'll be a lot more interesting. Although Dr. Coronado doesn't do a lot of cardiology anymore, oddly any more into venous insufficiency, but we'll still get his input. Okay, can get my slides on. So I have no disclosures. And everything I'm going to say, I don't have a lot of time to present all the slide background data information, but I will tell you that everything I say is going to come from the guidelines, consensus statement, or expert opinion, and I can guarantee you that the expert opinion is not from Dr. Oz. He was called to Congress because of a lot of what he said. There's no scientific data behind and he admitted it and promised to be a good boy, but I don't watch Dr. Oz. I doubt that will happen. Okay, so the first question regarding aspirin and ibuprofen. There's a monitor there as well if you want to relax, kick back.
Kick it?
You might be able to see that. Or if we can get 2 sets of questions, and we'll give you each a set and you can look down there. Okay, regarding aspirin and ibuprofen, which of the following do you recommend? 1, avoid ibuprofen if possible, or take it 2 hours after aspirin is taken. 2, avoid ibuprofen if possible and take enteric-coated aspirin if recommended. And 2, may be taken together but should be taken with meals. So on your response system, you will press 1, 2, or 3. I'll just give you a few seconds. 1, 2, or 3. Okay. And most of you answered 2. And the correct answer is avoid ibuprofen if possible, or take it 2 hours after aspirin. So this is the reasoning. You know, we cut ourselves, you shave, you cut yourself, platelets come there, platelets stick together and prevent bleeding. Well, if you take an antiplatelet agent like aspirin, it prevents platelet from sticking together, and therefore you bleed a little more. Now, aspirin has a very short half-life, 15 to 20 minutes, so it acts very quickly. Ibuprofen, on the other hand, has a very long half-life of about 8 hours. When you take non-steroidals, it blocks the action of aspirin at its effective site. They both compete for the same site on the cyclooxygenase 1. So think about it like this. I know Dr. Coronado always likes analogies. He's going to like this one, and I came up with it on my own. If you have a parking spot, and only either aspirin can get in there or ibuprofen can get in there. If aspirin gets in there, it will get into the parking spot, stay there for about 2 hours, and get out, and then ibuprofen can go in and stay as long as it wants. If ibuprofen takes that parking spot first, it'll stay there for about 8 hours before it gets out for aspirin to be able to get in there and become effective. So ibuprofen blocks that access site of aspirin. So you really should take your aspirin first and ibuprofen at least 2 hours after. Now, I recommend to most of my patients, and I'll get input from the panel, that it's best to take aspirin at night. Because one, what you will do is you avoid that ibuprofen interaction, because a lot of our patients take ibuprofen or non-steroidals and they'll take it the next morning. We also know that there's greater platelet surge, platelet activity early in the morning. So if you take your aspirin at night, you get greater benefit in reducing the surge of antiplatelet agents. Okay? Anything, Rich? Anything to add?
Yeah, so a couple comments. First, we only use non-coated aspirin. And the reason for that is that enterocoated aspirin doesn't work in about 25% of the adult population. Aspirin is mostly absorbed in the stomach. It's very poorly absorbed elsewhere. In fact, if you give rectal aspirin, most of the time it doesn't work. So we wanted to make sure that it gets into the system, and non-enterocoated aspirin, the same aspirin we took as babies, 81 milligrams is the preferred dose. For people that are very high risk, like recent acute coronary syndrome, people with stents, diabetics, real sick people, you heard a moment ago that aspirin has an extremely short half-life. So remember, it gets absorbed. If you give non-coated, it works within 20 to 30 minutes. It acetylates all the platelets that are currently circulating, and then the aspirin is gone. Any new platelets that are produced will not have an aspirin effect. You and I make 10% of our platelets new every day, but diabetics and sick people and people in the ICU make about 20% new platelets every day because their platelet production is increased. And hence, in the sickest patients, giving 81 milligrams twice daily is actually preferable. So in people where there is no such thing as aspirin resistance, you'll read that. I even read it this week. It is a myth. If you give intravenous aspirin, 99% of all humans have the same cyclooxygenase that's acetylated by aspirin. Aspirin resistance means aspirin non-absorption. That's why we give non-coated aspirin. So 81 milligrams non-coated once a day. I agree with Mo, preferably at night. In the sickest patients, you can give it BID.
Now, the cyclooxygenase 2 inhibitors, this interaction doesn't exist. So patients taking Celebrex, that's okay. But if they take non-steroidals, preferably take your aspirin and then take the non-steroidals 2 hours later. Agree, Rob?
Agree. After Richard's, I don't know how to turn this thing on, but dissertation, there's not much more to add. Nice job.
Thanks, Rob. He's my buddy.
Thanks,
You
Rob.
know?
We go back.
Okay, question number 2. Current dietary guidelines recommend how much of sodium intake per day? Some music? Okay. The answer is 37% said 1,500 milligrams. Okay. The correct answer is 2,300 milligrams, which is about a tablespoon of salt. That's the current guidelines. Now, you heard earlier, also in a lecture earlier today, there were 3 recent publications in August in the New England Journal of Medicine regarding salt and cardiovascular risk. In one study, the PURE study, 100,000 subjects, where the mean salt intake was 5 grams, showed that there was no, in fact, showed a J-curve phenomenon, that if patients took less than 1,500 milligrams of salt, that there was adverse outcomes. So the average, the debate with salt is unsettled, but it's going to be more in the 2.5 to 3.5 grams. In fact, there was an article in January in JAMA showing that 3 to 4 milligrams of salt intake is where really what patients should take. Clearly, more than 7 grams of salt is harmful, but less than 1,500, it's with everything we've seen in cardiology. Extreme rate control in atrial fibrillation didn't pan out, in fact, had adverse outcomes. Very low blood pressure didn't pan out. Extremes with salt intake, again. Same thing with everything. It's really moderation. So salt intake, 2,300 milligrams, but it's going to be more than, the average will be around 3 to 4 grams of salt, not sodium salt. Please Ed.
I have an opinion about this.
Okay.
As you probably find about most things. I completely disagree with this guideline, and here's why. I would base it more on epidemiologic evidence. So the study that Mo just quoted, first of all, didn't measure salt intake. It was a dietary inventory by people filling out, what do you eat? And then 20 years later, they look back and said, oh, the guys who said they ate this and that. I'm not sure I would consider that to be evidence. I'd look at the evidence that the history of peoples around the world. So the lowest sodium intake in the world right now is in the Amazon jungle, Stone Age tribes people. I spent a year there as a medical missionary. I didn't see any heart disease there. They don't eat 2,300. They don't eat 1,500. They eat 50 milligrams of sodium per day. And they have no issue with hypertension, hypotension, shock, or anything like that. The highest incidence in the world, the highest sodium intake in the world is in northern China, 6,100 milligrams per day for the average male, and they have a pretty high incidence now of problems. So I don't think that there's a correlation in a detrimental way with lower sodium intakes. What Mo quoted was, if you take people who've been eating a high salt intake their whole lives, and then in the middle age you lower their sodium intake part way toward what the indigenous peoples in Amazon eat, do those people do better? And the answer that he quoted is correct. They don't do better, but that doesn't mean that we shouldn't have been avoiding salt our entire lives. I think that's...
So the campaign from the American Heart Association of less than 1,500 milligrams, you agree with that?
I do, but and here's what the AHA has been trying to accomplish. They've been trying to go to Kraft and General Food and other places and say, please lower the sodium intake of processed food, which is where most sodium intake comes these days in America. And if you just lower it 5% every year and wean people off the salt, the body will become used to it. The young kids won't be exposed to a high sodium diet, which we've been exposed to our whole lives. And that should translate, by epidemiologic data, to lower cardiovascular event rates in the future. But that's different than taking a 70-year-old person who comes to your office and say, go from a 2,500 milligram diet to a 1,500 milligram. That's where the rub is.
Okay, so the debate is unsettled. Although the data from JAMA in January was in elderly patients more than 65 that showed there were no differences from 2,300 and 15 to 2,300. But current guidelines, 2,300. Okay, which of the following will not lower your LDL cholesterol? So at the bottom, you can see we have 58 responses. Good. I like this response system. 78 responses, 86 people, 100. Okay, 100, so it'll be a good percentage. All right, and the answer is 53%. See, correct, exercise. Now we know that exercise will raise your HDL. Exercise can help your triglycerides. Now if you exercise excessively and you lose weight, then certainly the weight loss will help lower your LDL cholesterol. But exercise alone, I just had a patient this last week, and his LDL hadn't changed. He told me he exercises like crazy, and then I asked him about his diet, and he said, well, I like to eat. So it's a combination. You know, whenever you look at these, it's a combination of exercise and diet that's going to help improve outcomes and improve our lipid profile. But the myth that exercise alone will lower your LDL is not true. You agree with that one, Rich?
Yeah, I do actually agree with that one, although I would have preferred if the question said your lower LDL particle number, because that's all I use. I don't use LDL cholesterol, so
now let me
better.
ask you on that point, because you know we had this lipid discussion, and
Yeah.
the previous I was always trained initially, check your LDL, and if the LDL is not a target, go to the non-HDL, and then treat the non-HDL. Now, even recently with the new workforce, ApoB was not given a nod to be added to the guidelines. So do you say non-HDL is adequate for particle number?
No, I don't. And the evidence was actually pointed out. One of the slides that was presented today in the LDL, so these very big databases now have been available where people have had both simultaneous LDL particle number. And so as was stated, measuring ApoB and LDL particle number are trying to measure exactly the same thing. Particle number is more accurate and reproducible. It's plus or minus 3% on paired specimens. So you could send your own LDL particle number every day the next 10 days, and all 10 numbers would be within 3%. ApoB is an immunoassay, which is less valid and less accurate, and it's plus or minus 10%. So for that reason, and for cost reasons, LDL particle number is $43 for Medicare. It's $27 by the HMO price in Los Angeles. It's an inexpensive test. It's the most precise and reproducible test, and it's not influenced by having eaten a meal. So you can just get it any time, and it's a very accurate number. That's the number we use, and indeed, as was shown there, particularly for the people you and I see most commonly, metabolic syndrome patients, diabetics, it's far more edifying than the LDL cholesterol or even the non-HDL cholesterol is in those people. So that's why we've switched to using that.
All right. Talking about exercise. The current CDC exercise guidelines for adults is which one of the following? So give us some music, Ted.
Which one do you do?
Correct answer? 3. Well, you heard this earlier, so great. You're paying attention. You know, the guidelines recommend, again, it's these extremes. If we tell patients you've got to exercise every day, and if they do it only 3 days a week, then patients will feel they haven't exercised according to what we told them. So if you look at answer 1, 30 minutes is 5 days a week, it's 150 minutes. But the guidelines recommend that some of us may have 2 days during which we can exercise, or 3 days during which we can exercise. So if we accomplish a total of 150 minutes, regardless of whether it's 3 days or 4 days, we get the number of minutes we need to exercise with 2 days of muscle strengthening activity. That's your legs, your thighs, your back, your abdomen, your chest, your shoulders, and arms. So that's the correct answer, 150 minutes. Now clearly, and moderate intensity means brisk walking. For patients who do vigorous activities such as running, then half of that is adequate, 75 minutes with 2 days. Of course, you can do more. More is better. But that's the guidelines, 150 minutes, moderate activity, 75 minutes, vigorous activity with 2 days of muscle strengthening activity, and more is obviously better. Okay. Trimethoprim sulfamethoxazole is associated with sudden cardiac death in older patients with which class of cardiovascular drugs? got about 100 responses. C, calcium channel blockers, and the answer is ACE inhibitors. Okay, ACEs and ARBs are associated with hyperkalemia in about 10% of cases. Trimethoprim sulfamethoxazole or Bactrim is also associated with hyperkalemia by decreasing potassium excretion in the distal renal tubule. This association was actually first noticed in hospitalized patients in New England in 2010 and published in the New England Journal of Medicine. Published in October in a population-based study in the British Medical Journal, in Ontario, Canada, 1.6 million prescriptions over an 8-year period was written for ACEs and ARBs. And they found 1,110 deaths in the first 7 days and 1,827 deaths in the first 14 days. And the assumption is, and this was age, sex matched, and the comparative antibiotic was I'll come to me in a second. That doesn't cause hyperkalemia. And they found that the assumption is that hyperkalemia causes excess sudden cardiac death in older patients. And the authors suggest that 3 sudden cardiac deaths per 1,000 prescriptions, which is not trivial based on the number of patients that take ACEs and ARBs and are given Bactrim or trimethoprim. So something that we need to watch and follow carefully if we put these patients on these antibiotics to monitor their potassium levels.
I have something to add to that.
Yep.
It's kind of a story about 15 or 20 years ago. We were studying for our boards, Dr. Khan and I, in Aspen, really nice hotel there. We were actually with the cardiologist that took care of Michael Jackson. He's a good friend of ours, but we don't practice the same way. But I wasn't feeling well, so this kind of covers the last 2 questions. And I was exercising a lot at the time. I was young, 15 or 20 years ago. Remember that? And something bad happened, but I just was not okay. And I was taking Bactrim at the time, no ACE inhibitors, though. And Mo can tell you about my lab results. So we ended up in the ER with a creatinine of 2.3 and a potassium of 5.7. And it was that, and I was taking something else too, but it wasn't a substance of abuse. I was taking, what was that? Creatine, right?
Creatine.
And I got chewed out, but I just thought I'd bring that up just to reminisce old times when
the comparative antibiotic in the trial was amoxicillin. Okay, next question. A patient presents to your office with lower extremity discomfort, edema, restless legs, or nocturnal cramps. What is the next study most likely to provide the answer with respect to the etiology? Okay, we have about 100 responses, and and you respond 3. Ankle brachial index. Okay, the correct answer, venous ultrasonography.
I get no respect here.
Yeah.
Okay, Rob, you work a lot of the venous insufficiency. Give us your input.
I don't know what the purpose of this question is, but I think it was to basically see how overlooked this disorder is. Put up the options there again, Mo.
There you go.
I think I have the question here. So basically this patient has lower extremity discomfort. It's very general. It could be arthritis, it could be fibromyalgia, it could be a statin medication, it could be anything. Restless legs and nocturnal cramps, and I think we see that quite a bit. But I think this question helps to illustrate how common venous insufficiency is, and it's basically 30 million Americans. That's about, if you chose ankle brachial index, it's a good call in general, discomfort and so forth. But that, if the ankle brachial index is abnormal, suggesting peripheral vascular disease, you're probably not going to get edema. Restless legs is not really a component of that. But it's a good try because peripheral vascular disease is quite prevalent, 8 to 12 million. Some people say as much as 15. But even looking at the prevalence of peripheral vascular disease, venous insufficiency, which is what I take care of now, is 2.5 times as prevalent. It's actually 5 times, I'm sorry, as prevalent. It's 2.5 times as prevalent as coronary artery disease. So it's very common. And when we, just one last little thing I want to add to that venous ultrasound, when you have a patient that has these symptoms, they have the swelling, they have the varicose veins, and they have the other components that suggest venous insufficiency, don't just order a venous ultrasound. Make sure you order the complete study, because the venous ultrasound is designed to do what? Make sure that the patient doesn't have a clot in the deep system. So what you want to do is you want a complete study or a reflex study, which will look at clot, look at any anomalies, look at the flow, and then diagnose the venous insufficiency. Just really quick on lower extremity venogram, we do those sometimes, very rare study. Lymphatic dye study, even more. And a cardiac echo, they might have it, but the real money here is venous ultrasonography, no pun intended.
So something go ahead, Rick.
No, I agree totally.
Something clearly we need to think about. I mean, a lot of our patients come in with edema, leg cramps. We don't think about this at all. So that's why I put this question in there. And I don't know if many of you know that Dr. Coronado had his first symposium on venous insufficiency and diseases this year with great speakers. And are you planning to have another one next year, Rob?
We are, Mo. Thanks for that. This was not planned or anything. One of those great speakers was Dr. Khan. So we are. That's what he really meant. So yes, we're going to have it. Pick up a save the date, and if not, you'll get one.
You had Patty Thorpe and a lot of other speakers on anticoagulants, and it was terrific. And I think it's great education for our community. So when it does come, please attend. Okay, the next question. A 46-year-old man with a history of diabetes and tobacco use is referred to you for leg discomfort, intermittent claudication, after walking 7 to 8 city blocks. He does not have to stop to rest. His ABI, or ankle brachial index, is 0.8. He subsequently had a duplex ultrasound which revealed total occlusion of both superficial femoral arteries, or his SFAs, which was then confirmed by CT angiogram. Which of the following do you recommend? Okay. Angioplasty and stenting. The correct answer? Counsel him regarding his risk of coronary artery disease. So, if there's anything I want you to go away with today, because we've pounded this over the years, but I'm going to stress on the ankle brachial index, and everybody's going to go away knowing exactly what's the ABI. It is very important, very accurate, very effective. So it's simply measuring the blood pressure at the ankle and measuring the blood pressure at the brachial. And let's say the blood pressure at the ankle is 120. Normally it's about 10 points higher, but let's say 120. And the blood pressure in the arms, you take the higher arm. And the reason they take the higher arm is in case there's stenosis or blockage in one of the arms, so you take the higher arm. So 120 at the ankle divided by 120 at the brachial, 120 divided by 120 is 1. So normal ankle brachial index is about 1. And I'm going to tell you why it's so important. Let me just say it before I forget. The ABI is a universal language. If somebody calls me on the phone, if a physician calls me and say, the patient has a stenosis of the peroneal artery and the posterior tibial artery, and trust me, most cardiologists don't even know what that means. But if somebody tells me the ankle brachial index is 0.4, and when I'm finished here, you will know. When we say 0.4, you'll know exactly what it means. And that's all I need to know. I don't need to know more than that to tell me the severity of the disease. It's 95% sensitive and almost 100% specific. And if you compare it to the pap smear, compare it to the mammogram, you can see how specific and sensitive an ABI is. So a normal ABI is about 0.1. An ankle brachial index of 0.9 is borderline PAD. Now, as you get lower, it means the patient has more significant PAD. So if it's 0.8, it's moderate but more severe. 0.7, moderate but even more severe PAD. Now, when the ankle brachial index is 0.4, that patient has severe disease. And when it gets to 0.3 or less, that patient has rest pain. In other words, lying supine, they're going to have discomfort in their legs. They often have to sit up and dangle the leg to get some circulation by gravity. And 0.1, I got a call about 10 days ago from asking me to intervene on a patient who has an ankle brachial index of 0.1. Now, when you say 0.1, you know that is critical. This patient is about to lose their leg, about to have an amputation. So I want you to know. So again, if you take our patient here, and they called me and said the ankle brachial index is 0.8, I know it's not that bad. The patient really didn't have to have an ultrasound, but certainly didn't need a CT angiogram because it's not that bad. And we can talk to the patient about exercise, and I'll get into all of that. But you've got to know it's a universal language. Know the ABI. Don't worry about the severity of the stenosis. That's for the interventionalist, how he's going to intervene, what he's going to do. He needs to know how to approach his intervention. So know the ABI and don't focus so much on the severity of the disease. So know the ankle brachial index. The patient survival, an ankle brachial index, the lower it goes, the worse total mortality and all-cause mortality and cardiovascular disease. In fact, for every 0.1 the ABI goes down, the patient's relative risk of an ischemic event increases by 10%. So very significant, very important. If you look at the 5-year survival of an ABI of 0.9, it's 91%. And the 5-year survival of an ABI of 0.5, only 63%. Here's the patient. This is the anatomy of the patient's superficial femoral artery. And you look here, this whole thigh, that's the superficial femoral artery. And right here next to it is what is called the deep femoral or the profunda femoral. Think about this as a freeway. So cars are going down and there's a narrowing here and they cannot go, they can go around this detour. So if we tell the patient to exercise, they can build collaterals, preferably supervised exercise. But if a patient can walk 45 minutes to an hour, 3 days a week, now they'll tell you I hurt. So they walk, they hurt, they stop for 5 minutes, walk again, stop for 5 minutes when they hurt, walk again. But do that for an hour, 3 days a week. That's as good as angioplasty and stenting, especially of the superficial femoral arteries. So exercise is very, very important. Now, one of the choices was Celestazol or Platol, and we know it helps improve walking distance. But don't give it to patients who are not active and not walking. I see patients coming in a wheelchair, in a nursing home on Platol or Celestazol. It's not making a difference in outcomes. It's just to help improve their walking distance. And Trantol or pentoxifylline, you can see, has marginal improvement compared to placebo. So really speaking, it doesn't make a difference. If you're going to give it, use Platol. So the correct answer was talk to the patient about his cardiovascular risk. If you have disease in one vascular bed, you're going to have disease in the other vascular beds. When patients have PAD, they have systemic disease. It's telling you that they're going to have cardiovascular disease. In fact, if somebody has PAD, they have a 4 to 5 times risk of having an MI and a 2 to 3 times risk of having a stroke. So we got to talk to them about coronary artery disease. Believe me, where I came from in the developing world or the third world, the ABI is a poor man's cardiac catheterization. It's telling you they've got coronary artery disease. So when you see that, you got to counsel the patient on coronary. Anything want to add? We're good? We'll save you for the tough ones, Rich. 68-year-old man with chronic tobacco use is referred for fatigue and cramping of his right buttock, thigh, and calf when walking up a hill near his house. On physical exam, he has 2+ pulses in the right femoral, popliteal, dorsalis pedis, and posterior tibial. Which of the following is the most appropriate next plan of action? Okay. Refer for ABI assessment with exercise. Now, this is one of the limitations of the ankle brachial index. When patients have aortoiliac disease, now let me just backtrack. This patient has buttock discomfort in the thighs. If you have a blockage up here in the distal aorta, or right here by the iliac arteries, your pain is going to be below it. So if you have a stenosis in your aortoiliacs, you're going to have discomfort in the buttocks and in the thighs. If your stenosis is in the popliteal, behind the knee, you're going to have discomfort in your calf. If the stenosis is more in your calf, you're more likely to have discomfort in your foot. So it's telling us that because of his discomfort in the buttock, that the discomfort is more in the aortoiliac arteries. And that's where they can develop collaterals, and sometimes you can feel their pulses. So the ABI is not very sensitive for aortoiliac disease. And this is where you do an exercise ABI, okay, an exercise ABI. And this is the aortoiliac artery. You can see stenosis. I just drew this. And here's a patient with high-grade aortoiliac stenosis, stented, with significant improvement. So an exercise ABI will tell you how far they can walk. It'll tell you what's the true, whether they truly have PAD. And if your ABI drops 20% from your resting ABI, that confirms significant PAD. So basically, if your suspicion is that this is PAD, and your ABI is still normal, then you should get an exercise ABI. And it's sometimes very easy if you do an ABI, just do plantar flexion. Have the patient stand on their toes, up and down for about 7 or 8 times. Repeat the ABI and you'll get a 20% drop. And you will know that that is significant peripheral arterial disease. And remember, not all patients present with typical claudication. Only about a third of patients. Most patients will present with just heaviness or tiredness in their legs when they walk. Okay, next question. 68-year-old woman complains of heaviness in both calves with exertion. Symptoms are relieved after about 5 minutes of rest. She has a history of hypertension, diabetes, and hyperlipidemia. She does not smoke. Her ankle brachial index is 1.4. Which of the following is the most appropriate diagnostic test to evaluate her exertional leg discomfort? Okay. All right. 1 and 3. And the correct answer? Toe brachial index. Okay, I'm trying to make sure you guys, when you leave here, you know the ABI. Okay, that's the whole point of all of this. Okay, so now remember, what happens is, we talked about ABI 1, then 0.9, 0.8, 0.7, 0.4 being very severe, 0.1 being critical. But what about that high ABI more than 1.3? This you'll see in diabetics and patients with chronic kidney disease. What happens is their vessels are so calcified and hard. Remember, when you do an ABI, you're putting the blood pressure cuff around to the vessels and you're inflating the cuff. But the vessels are so calcified and hard that you cannot compress those vessels, and you get a falsely high ABI. So when you get a falsely high ABI, that's also indicative of significant disease. So the toe, for some reasons, I don't know if Rich knows, but I don't know, for some reasons, or Rob, the toe doesn't calcify like the rest of the vessels. And so if you get a toe brachial index, and most of the machines now, the ABI machines, will give you a toe brachial index, and if it is less than 0.7, that indicates significant PAD. Do you know, Rich, why? I don't know
it's
why.
the same reason the radial artery doesn't. I mean, I don't know.
Just doesn't calcify. So toe, Rob?
What I've heard is it's just like the coronaries, they calcify in the proximal segment, but not distally. I mean, that's the best guess of what I've seen, but I don't know if anybody knows.
Yes.
Now, it's probably been about 2-3 years since I tried to order one of those and couldn't get anybody to do it. But you said now most of
Yes, most of the newer ABI machines will print out the toe ABI as well. Okay, so you can see here the association between ABI and all-cause mortality. If the patient's ABI is less than 0.7, and as the ABI goes lower, the mortality increases. And also, if the ABI is more than 1.3, that also indicates greater adverse outcomes. So the ABI, again, is very important. Now, one of the differences between PAD and back discomfort, because back pain can cause similar discomfort as PAD. One of the differences is that when it's peripheral arterial disease, the patient will say that my discomfort starts after 1 block, for example, but it's very predictable. He'll tell you every time it's after 1 block. If somebody says, when I walk to the mailbox, his discomfort will be every time he walks to the mailbox. Lower back, some days he'll be able to walk more than others. Some days he'll be able to walk 3 blocks. Some days he'll be able to walk half a block. That indicates more that his discomfort is from his back. Also, with back pain, you're more likely to get some numbness and some tingling. And with PAD, when the patient hurts, if he just stands for a while, and it won't take very long, the discomfort will get better. But when it's your back, you're more likely to want to sit or change your position, and it won't take just a few minutes to get better. It'll take 20, 30 minutes for your discomfort to improve. So that's how you differentiate between claudication and pseudoclaudication. Please chime in, you guys, anytime you want.
I have something that's, just as Dr. Khan said, every time. Not on Mondays or Wednesdays, none of this. Sometimes I can walk a block, sometimes I can walk 5. It's usually reproducible at the same distance every single time. And it's useful for us because we do see patients that have peripheral vascular disease. We've gotten a CAT scan. They have disease in the popliteal at the level of the knees or calf, and we don't know whether we should intervene on that patient for whatever reason, higher risk. And they're saying, I'm hurting a lot. And I've had these patients where I ask them, okay, look, tell me your symptoms. Well, sometimes I can walk 4 or 5 blocks, but sometimes I can walk 1 block. Just as Dr. Khan said, that's most likely pseudoclaudication, and you're not, even though they have peripheral vascular disease, it helps you differentiate that it's not true claudication, because once again, true claudication is the same distance every single time.
Okay, next question. So I hope that all of you now know what an ABI and can help decide who really needs an intervention or who really needs diagnostic imaging. Okay, so we'll go back to this, our question. Next question is, a 55-year-old man is on 3 antihypertensive agents, but continues to have elevated blood pressure. What is the most likely etiology for the patient's resistant hypertension? I'm glad Richard is here for this answer. Okay. Obstructive sleep apnea. Very good. Okay, so I couldn't find, Rich, I couldn't find a lot of data on this. There was an article in 2001 in the Journal of Hypertension that said up to 83% of patients with resistant hypertension have sleep apnea. But in an abstract in 2014, looking for secondary causes of hypertension, followed 125 subjects and found 64% of patients had obstructive sleep apnea. About 5% had primary aldosteronism. 2.5% had renal artery stenosis. About 1.5% because of oral contraceptives, and about 1% because of thyroid dysfunction. And there's very limited data, so I'm curious, when somebody comes in, we rarely think about this as a cause of, even wasn't mentioned in the lecture today.
Yeah, so I would have preferred had the question said, of the following, which is most likely, and the reason is the most likely is the person's not taking their medicines, okay? So you always have to understand that,
true.
and they will swear up and down, but when the renal artery ablation studies were done, they did a big study in Germany where they took 1,000 people referred for resistant hypertension, meaning they were on 3 antihypertensives, one of which was a thiazide-type diuretic, and they were looking for, did these people have blood pressure that might have been amenable to ablating their renal artery. And it turned out when they did serum and urine blood specimens to pick up hydrochlorothiazide blood levels and things like that, fully a third of the people had no meds in their system whatsoever, and these people swore up and down that they were taking their meds. So that eliminated a third of the resistance off the bat. 20% of those people had primary hyperaldosteronism, measured either by renin aldosterone blood level or by just giving them spironolactone and curing their resistant hypertension. The problem with obstructive sleep apnea is that it's so common in the heart population. So if you just take random heart failure patients coming to my heart failure clinic, 50% have sleep apnea. Now, does that mean if I treat their sleep apnea, it'll cure their heart failure? That study, unfortunately, didn't pan out. In the heart failure world, there's a little difference. They have central sleep apnea, most commonly. It's a Cheyne-Stokes type ventilation where they just stop breathing because the brain center for breathing doesn't work. It's not like they have upper airway obstruction, so that's a little different animal. I do think, though, that there's a role when if the person, and you can be convinced that they're taking their medicines and they're reasonable doses, you could either do a sleep study, which has a high likelihood. However, the CPAP studies have not borne fruit in terms of outcomes benefit. That's the rub. They'll sleep better, maybe their blood pressure will be better, but at least over the duration of the trial, we haven't shown that it helps outcomes. So a lot of people, including me, think that if somebody truly is taking their meds, the next step to do is give them spironolactone and, quote, see what happens. Because if their blood pressure is now normalized, you may not need to do any further analysis.
Do you think sleep apnea contributes? So what about atrial fibrillation?
Yeah, there's some pretty compelling evidence that. So in the AFib world, and we have an atrial fibrillation research center, and we have thousands of people with atrial fibrillation, and I'll tell you that there is evidence now that if you ablate these people, that if they have sleep apnea and you've ablated them, there's a percentage that will recur over 30%. If they have sleep apnea, you ablate them and you give them CPAP, it's like 50% reduction in recurrence of atrial fibrillation. So the evidence is more compelling, and the theory there, of course, is that during hypoxemia at night, they have epinephrine surges and norepinephrine surges that promote the development of atrial fibrillation. So I actually think the data are more compelling there.
Okay. Next question. A 54-year-old obese woman with hypertension and diabetes who also smokes is concerned because her father had a myocardial infarction at age 54. Which of the following components of this patient's presentation is associated with the greatest risk of an acute myocardial infarction? So when patients come and ask you what is the greatest risk factor, okay. Currently smoking is correct. Okay. This comes from, and I'll be happy again, Rich, if you give us your comments. I appreciate it. This comes from the InterHeart study. The InterHeart study was a study of 30,000 patients, 52 countries. In fact, the questionnaire was in 11 languages. And what they looked at 15,000 first heart attacks, patients that were admitted to the CCU or the cardiac ward, and looked at their risk factors. And they found that dyslipidemia, which I didn't put here, dyslipidemia had a 4-fold increase in the risk of having a heart attack, cigarette smoking a 3-fold increase. Dyslipidemia was more associated with the younger population, men less than 55, women less than 65. And cigarette smoking had a graded relationship. The more you smoked, up to 40 cigarettes, the more you smoked, the greater your risk. Those that smoked 1 to 5 cigarettes had about a 38% increased risk of having an MI, and those that smoked 40 cigarettes a day had a 900% increase. And if they cut their cigarettes in half, they lowered their risk by half. So clearly, when we talk to our patients about cutting back, and those of you that have convinced them to stop smoking are making a significant difference. Rich?
Yeah, I totally agree with that. And there is an abundance of evidence now that if community-wide smoking is reduced, the rate of heart attacks goes down. The first evidence of that was in Helena, Montana, and Helena's kind of a hard-scrabble mining town, and they had a lot of bars there, and they passed a law that forbade smoking in restaurants and bars, okay? That law persisted for 1 year, and then it was rescinded because the bar owners were upset that their business went down. But during that year, the number of heart attacks in Helena went down by 50%. And then as soon as the law was rescinded, the heart attack rate went right back up to what it had been before. And those data, you could read that paper. They were criticized for numbers, et cetera. But that study was replicated in other countries. And when laws, and I live in the People's Republic of Santa Monica, I can tell you that when we pass laws to cut smoking down, you can't smoke anywhere in the city of Santa Monica right now except in your own home. Right? It's not legal to smoke in a park or on a sidewalk or in a supermarket or in a restaurant or a bar or on the beach or anywhere else. Our heart attack rate, it's one of the reasons our heart attack rate dropped, and I mentioned this earlier, and it dropped such that our smoking rate in our population right now is under 2%. And that has translated into not only reduced heart attacks in smokers, but in their families and in the people in the restaurants near them and in the bars near them, because secondhand smoke increases heart attack rate. The amazing thing about these data is the heart attack rate fell within 30 days. So this isn't because smoking aggravates atherosclerosis, it's because smoking triggers vulnerable plaque to rupture and all those things and cause acute MI.
Okay, next question. A 30-year-old man with diabetes and PAD is referred for evaluation. He denies history of angina, vitals, physical exam, and EKG are all normal. Which of the following medications should be prescribed to reduce his cardiovascular mortality? Okay. Aspirin. And the correct answer? Okay, Richard, HOPE study. I'll have you comment. I know you've lectured extensively on the HOPE study.
So, obviously, a 30-year-old with atherosclerosis, I mean, this guy's clearly an outlier. And my suspicion is that he has familial hyperlipidemia, actually, because even if you're diabetic, unless he's a type 1 diabetic for 20 years, it's unusual to have peripheral arterial disease at age 30. The reason aspirin didn't come up here as the one that should be prescribed is because, unfortunately, there's a peripheral arterial study and actually a diabetic trial, both of which failed to show mortality benefit with aspirin, which was quite strikingly surprising to those of us who would have thought that it would have led to lower vascular events, but it didn't, right? So those data are out there, unlike coronary patients, which clearly the data show that aspirin helps. That's why aspirin wasn't there. ACE inhibitor, there are a bunch of ACE inhibitor trials. The pivotal one that was mentioned a moment ago was using ramipril years ago, and they took people at risk. Now, these weren't, quote, hypertensive people because the average blood pressure in the trial was 139. But if you gave ramipril at that time, and it was, interestingly, an evening dose of ramipril, maybe getting at this when is the timing best, but there was a reduction in morbid and mortal events in high-risk people given an ACE inhibitor, specifically ramipril at that time. I will tell you, though, that the risk-benefit correlated with the blood pressure on entry. So even though the average blood pressure was sort of borderline, the people who derived the most benefit were the hypertensives in the population. And if you went into the HOPE trial with a blood pressure of 120, at least over those first few years of the trial, you didn't benefit from the ACE inhibitor. So it may have been that the data were skewed a little bit by hypertensives, but those are the data, and I would agree that ACE inhibitor, but boy, I'd look real hard at this person's lipids.
Yeah, this question was taken from the American College of Cardiology self-assessment. And yeah, not a lot of strong data also in patients less than 40 with aspirin. Beta blockers we know post-MI. So ACE inhibitor is the correct choice.
Yeah, although I'd be careful about the statement you just made. Beta blockers post-MI were only helpful in people with LV systolic dysfunction. So what drove the bus there was the pre-stent era when people had pretty big infarcts and they had low EFs, and no question, beta blockers help those people. A typical person coming in today with a acute coronary syndrome, a troponin of 2, normal LV function, gets a stent. The evidence tells us beta blockers does not lower the morbid and mortal events, at least over the short term in those people.
Okay, good question, because a lot of times, Rich, I'll ask you, Rob, you too, patients that have had an MI in the past, stented, come in, they've been on their beta blocker because it's a core measure. 2 years later, ejection fraction is completely normal, and they're tired or they want to get off it, blood pressure, and, you know, what do you do? I take them off it.
I do too. And that's good medicine. It may be bad for the administration at the hospital or whatever, because they are being, I will tell you, I was in a meeting this week where we were choosing our core measures for quality, and we specifically did not choose the beta blocker so that we wouldn't be in the quandary of giving a person a beta blocker who didn't need it just so that you could tick off the box that you gave a beta blocker to a coronary patient. And we need, as a society, to avoid doing something to tick off a box when it's not in the patient's best interest.
I couldn't agree more. I don't know how many of you guys have taken a beta blocker, but just you can take a low dose just for kicks. I mean, it is I used to take one when I presented at the university or something, and my heart rate would go up to 120, 130. I knew what I was saying, but I just couldn't talk. And so I started taking a low dose of a beta blocker. So aside from asthma, bronchospasms, and and impotence in some individuals and so forth, severe peripheral vascular disease, and the constriction of the vessels that can lead to precipitating even more ischemia and so forth, the feeling of can't do anything, you're not sleepy, you're just sitting there and can't even move. So unless there's like Rich and like Dr. Khan say, that unless there's something more of a benefit than just checking a box, really evaluate that patient's treatment.
I'll tell you, the only time I took a beta blocker and it worked was when I was in fellowship before a presentation. Calm me down. Don't make me nervous. It does work. It helped.
Yep.
All right, so I have a few questions on atrial fibrillation because this wasn't covered today, and we're going to try to nail this down as well, just like we did with the ABI. Okay, a 48-year-old woman is referred to you for paroxysmal non-valvular atrial fibrillation noted on telemetry when she was in the hospital for carotid endarterectomy. She's asymptomatic, no history of hypertension, diabetes, TIA, or stroke. She's on aspirin and simvastatin. You recommend. Okay. Roughly even. Continue aspirin, stop aspirin, and start anticoagulation. And the correct answer is 2, stop aspirin and start anticoagulation. I'm going to come back to this question. Let's ask this question and then I'll go back. The 2014 ACC/AH guidelines for the management of patients with atrial fibrillation suggest that all patients with non-valvular AFib should be stratified for stroke risk using what risk calculator? Okay. CHADS VASc, roughly about even. And the answer is the CHADS VASc score. Most guidelines now are pushing towards trying to prevent stroke reduction. And if we use the CHADS VASc score, we're more likely to help patients prevent a thromboembolic event. So let's just look at the score very briefly. These are different conditions I'll go over, and patients are given a point, and we total up the points. So C stands for congestive heart failure. If a patient has congestive heart failure, they get 1 point. H is for hypertension, 1 point. A is for age 75 or greater, 2 points. D is for diabetes.
65 is 1 point, by the way.
It's under VASc. I'm coming to that, Rich. D is for diabetes. S is for stroke or TIA, 2 points. V for vascular disease, 1 point. A for age 65 to 74, 1 point. S is for sex category females. Now this is on all your iPhones, iPads, or Google. So that's the CHADS VASc, and you total up the points and you can look at the patient's risk of a thromboembolic event. Now this table is from the CHADS score, okay, the old CHADS score. A score of 0, the patient is low risk. Here they say therapy aspirin, consideration aspirin, or do nothing. And I can tell you that there's more and more data. In fact, the European Society of Cardiology has said there is no role for aspirin in atrial fibrillation. I talked to 2 electrophysiologists before this lecture, and both of them told me no role for aspirin. There was a trial, the SPAF trial in 2001, that showed that there was some benefit of aspirin, but since then there's no randomized trial, none, to show that aspirin will benefit patients to prevent them of having a thromboembolic event. So most extra electrophysiologists or experts will tell you no aspirin for AFib, no role of aspirin, unless they're taking aspirin for primary prevention or secondary prevention. If a patient has a score of 1, this says moderate risk, aspirin or anticoagulation. And here it says have a discussion with the patient preference. Again, it says no aspirin. Now, so they usually say nothing. But if you feel you should have this discussion with the patient, I'll tell you in the last 2 months, I've seen 2 patients with a CHADS VASc score of 1 who had a TIA and 1 who had a stroke. That's making me rethink what I need to do with a patient with a CHADS VASc score of 1. But if their CHADS VASc score is 2 or more, that patient is at a greater risk and need to be on anticoagulation. Any comments before I go on, Rich?
Yeah, so a couple things. First, about this patient, I would have answered none of the above because I would have continued aspirin and started anticoagulation. Why? Because she had a carotid endarterectomy. She needs aspirin for that. The reason aspirin prevented strokes in the study that Mo quoted is because a whole bunch of those people had carotid disease. And guess what? Aspirin helps prevent stroke in people with carotid disease. Aspirin is useless for preventing macroemboli from AFib. So this person has 2 reasons to have strokes. They have carotid disease and they have AFib. Unless there's a real strong reason that you want that person to have a stroke, in our place, she would get both aspirin and an anticoagulant, either warfarin or one of the 4 new agents.
Okay. Now, let's go back to our patient, and Dr. Wright just answered the question. If you look at this patient's CHADS VASc score, no congestive heart failure, no hypertension, age is below 65, but she's a woman, a female, and she has vascular disease. So her CHADS VASc score is 2, and she needs to be on anticoagulation. So again, CHADS VASc score. Okay.
Question: is this part of the once a fibber, always a fibber?
Yes.
She never goes into it.
Now,
Yeah, so unless somebody has a proximate cause of atrial fibrillation, example, you see somebody who's young and has acute pericarditis, viral pericarditis, and they have AFib and their pericarditis goes away, we don't consider that to be a fibrillator. Otherwise, and maybe a post-thoracic surgical patient who happens to have post-op AFib. Otherwise, somebody like this who doesn't have a reason to have AFib is going to have AFib again. And most of them, they don't recognize when they have AFib. Implanted monitors that are put in people show that 90% of atrial fibrillation paroxysms are not appreciated by the patient. So just asking them, have you had any atrial fibrillation, you're going to miss 9 out of 10 episodes of AFib. It only takes 5 minutes of atrial fibrillation to double your risk of stroke, and 5 hours of AFib quintuples your risk of stroke. So this old saw that, if you're having AFib for a day or two, don't worry about it, is completely wrong.
What about if you put them on a Holter monitor for?
Doesn't. So Holters, unfortunately, so the data I just quoted come from these new monitors that are subcutaneous. You implant them, they pick up, they take 100 million heartbeats, 3 years battery duration. And if you do that, what you'll find is that Holters and periodic EKG monitoring is insufficient. I mean, after all, you're doing a snapshot of 100,000 heartbeats of 36 million per year when you do a Holter. So it's just insufficient to pick up paroxysmal fib. The only time that we will absolutely take the data are on somebody who, a patient of Mohs who has a defibrillator or a pacemaker in place in which that device keeps a complete track of the arrhythmia. If that person has proven to us they go 6 months with no arrhythmia, then we'll have a discussion about, okay, is it safe for us to remove you from whatever the anticoagulant strategy you've put the person on.
But if the patient has AFib on the Holter,
if they have AFib, so remember the data about stroke. So if you look at these AFib or the Framingham data or any of these AFib trials, if you have atrial fibrillation proven by EKG once, not due to pericarditis or thoracic surgery, you've entered the AFib group, you're 5 times more likely to have a stroke. Just once. Even if you're in normal sinus rhythm today. Because what you just said is true. If you've had AFib, you've proven that you can have atrial fibrillation.
this is very important for a lot of you who perform Holter monitors. If you see that the patient has atrial fibrillation on the Holter, that patient is at significant. And trust me, we say thromboembolic, and I've seen it. I've seen the thrombus go down the right arm. The patient came in with a cold arm. In fact, 48-year-old woman was given TPA and bled in the brain. Seen thrombus go down into the renal arteries and renal artery stenosis and acute renal failure, go down the lower extremities and cause acute limb ischemia. So it's not just the stroke risk, it's a thromboembolic risk. Okay, this was our question, so next. All right, in the choices I mentioned has bled. Has bled is recommended by the European and Canadian Society of Cardiology as a very practical, very easy, user-friendly tool to assess the patient's risk of bleeding in the next year. So it's great when you want to have a discussion with the patient about anticoagulation. So this again is an acronym. It's useful to use. It's available on all your smartphones. And has bled stands for H for hypertension. Again, they're given points, 1 point. A for abnormal liver or renal function. So if the LFTs are 3 times higher than normal, or the bilirubin is elevated, or the creatinine is more than 2.3, or they're on dialysis, they'll get 1 for liver, 1 for renal. Stroke history, 1 point. Bleeding predisposition, if they bled or thrombocytopenia, anemia. Labile INRs, if the INR is less than 60% of the time is therapeutic. Elderly patients more than 65. Drugs such as non-steroidals or antiplatelet agents, and alcohol more than 8 drinks a week. And you tally up the points. If they have 3 or more points, these patients are at greater risk of bleeding. So this is a good tool to discuss with the patient, but also a good tool for them to look at their risk and modify their risk factors. Perhaps they're drinking, they'll cut back on the alcohol if they don't want to bleed, or if the blood pressure is poorly controlled, more than 160, they can comply. If they use NSAIDs, they may be able to stop it. So it's a very easy, practical tool that you can discuss for that patient who is at risk of anticoagulation. Okay, a 74-year-old very active woman with atrial fibrillation is referred for pre-op evaluation. She has a CHAS-2 VAS score of 6. No history of a TIA or stroke. She is on dabigatran or Pradaxa, and her renal function is normal. Regarding holding anticoagulation for her upcoming surgery, you recommend. Okay. Very good. Very good. Okay. Now, we face this very commonly. Patients need hip surgery. Patients need knee surgery. They're on these anticoagulants. What do we do? Who should be bridged? And by the way, the choice of how long you should hold the anticoagulation for, some of the newer agents, 1 day, 2 days, 3 days. What I usually use and tell my patients is to remember 2, 4, 6. You hold it for 2 days for any of the newer anticoagulants, 2 days for minor procedures, 4 days for major procedures. Plenty. Where does the 6 come in? If they have chronic kidney disease and a GFR of less than 30, then I say 4 days for minor procedures, 6 days for major procedures. So 2, 4. 2 for minor, 4 for major. If they have chronic kidney disease, 4 days for minor procedure, you hold it, 6 days for major procedure. Now what about bridging? Here's some examples. If a patient had a previous stroke or a TIA, they need to be bridged. Mechanical mitral valves, they need to be bridged. Mechanical aortic valves alone usually don't need bridging, but if they have additional risk factors, they need to be bridged. AFib with multiple risk factors. We stop it often without thinking, but if a patient has a CHADS VASC of 1 to 2, they're low risk. 3 to 4 is moderate, but if their CHADS VASC score is 5 or more, they need to be bridged. And then DVT. If they had a DVT within 3 months, they need to be bridged. If it's 3 to 12 months, they're at moderate risk. More than 12 months, low risk. And if they've had an event when it was stopped before, and we've seen quite a few of these where they have a history of TIA when they stop their anticoagulation. And something I never thought of, recent coronary stenting. They need to be bridged if we have to stop the antiplatelet agents. Input?
Yeah, so the problem with bridging is there is no evidence in the world that bridging makes a difference. There are 2 trials currently underway using enoxaparin to try to prove or disprove whether we should consider bridging. I would agree that those things listed are reasonable, but I can tell you that a recent meta-analysis was done of people who were bridged versus were not bridged, and the event rate was worse in people who were bridged. So just be cautious when expert opinion, which is everything that you just saw there is expert opinion, makes sense, seems logical, but remember there's a downside to giving enoxaparin, and that's bleeding, and particularly intracranial bleeding, et cetera. So do I do some of those things? For sure, like he said. A perfect example, I had a patient, AFib, was on warfarin in the older days, and this guy had AFib and a mechanical valve. He had his warfarin stopped for a colonoscopy, and he presented to the ER with a hemiplegic stroke, decerebrating, et cetera. We gave him lytic therapy, got better. 6 months later, I didn't even know about this, it was stopped again for a colonoscopy, and he presented with a second stroke. Now, if somebody has already stroked, come on. Maybe the guy doesn't need a colonoscopy, would be what I would say. But, so
all right. Regarding her anticoagulation, you also recommend Pradaxa cannot be taken while she's NPO, since it must be taken with food. May be taken via NG tube. If she has this should have said may be crushed and taken via NG tube. Should be taken with a full glass of water. Okay. Wow, great. Yes, it should be taken. You should never chew, bite, or crush it, because you may it'll very quickly release its active ingredient, and you may bleed. It can be taken with or without food. We tell patients to take it with food because of GI side effects, but it can cause esophageal ulcerations and must be taken with a full glass of water. That's in the package insert. Should be taken with a full glass of water. Okay, a 76-year-old man with a history of TIA, hypertension, diabetes, prior MI, heart failure, underwent implantation of an AICD. During his routine 3-month check of his defibrillator, he is noted to have paroxysmal atrial fibrillation. 6 episodes, more than 15 minutes. He has fallen 3 times in the last month, secondary to gait disturbance. Do you anticoagulate him for his atrial fibrillation? Okay. Yes. Very good. Answer is yes. Okay. Now, this comes from the publication in the Archives of Internal Medicine saying that we under anticoagulate the elderly patients. And it looked at the fall risk versus the risk of bleeding from anticoagulation. It was a very nifty analysis, I'll tell you. It said that anybody who ventures to guess how many times you have to fall before you say, you know what, we need to stop anticoagulation. I'll give you $10 if you can tell me. Not really. 300 times. Yeah. That's about 1 fall a day. 300 times you have to fall before we say, you know what, you need to stop anticoagulation. Now, obviously, we don't do that in the real world. And I'll get both of your opinions, but it basically, the point was, you know, we're under anticoagulating our elderly patients, and the risk of falling or the risk of bleeding from falling is not any greater in this elderly patient population. Do you anticoagulate?
Yeah, for sure. So fortunately, we have other options now, but let me tell you, so the data that Mo just quoted came actually from an emergency room study. And what they did was they took geriatric patients who had fallen and hit their head enough that the ER doc felt compelled to order a CT scan to rule out bleeding into the head, okay? The yield on ordering those CT scans, and remember, these were old people who fell, struck their head, and the ER doc felt compelled to order a CT scan, was 1 out of 292 CT scans showed a bleed. And that's where that number that Mo quoted came from. So those are the data. The problem is that people then took those, the fear of falling and hitting the head and saying, if you're 80 years old, I'm afraid you're going to fall, risk of falling, I'm not going to anticoagulate, and therefore fewer than 50% of octogenarians in the U.S. with AFib are not on an anticoagulant. That's terrible medicine. So we anticoagulate all those people. Now, a month ago, an alternative stroke prevention approach was approved by the FDA, and that's called the Watchman device. It's a little umbrella that's erected within the left atrial appendage. It's equally effective at anticoagulation in terms of preventing stroke. In fact, it beat warfarin head-to-head in 2,000 patients. So that's an alternative. And in somebody like this, especially if they've fallen and had a subdural, for example, then in our institute, they would get a Watchman device, and therefore you can have your cake and eat it too and avoid anticoagulation.
You know, my 2 cents is people talk about this data, and you can read studies and articles and publications till the cows come home, but always exercise your judgment. You know, if it's 300 or 100 falls, you know, we run across, I also anticoagulate them, but I've run across patients that have paroxysmal atrial fibrillation, have not had an event, and the last 3 falls, one was an intracranial trauma that left him with seizures, the other was a fractured hip. So there are falls and there are falls. So always use your judgment as to, you know, exactly what they mean by falls.
Yeah, absolutely.
If it's just a lack of balance and so
Rob,
forth.
let me ask you, while I'm at the issue of all this debate of aspirin, in venous disease, aspirin, anticoagulation, any comments, thoughts?
Well, in venous disease, first of all, anticoagulation, I think you all know it as well as I do for DVT, and so everybody should be anticoagulated unless contraindications to a DVT. But we deal a lot with superficial thrombophlebitis. You'll see that a lot, and this is one of the things, I'm glad you addressed that, Mo, because I hadn't planned on talking about it, but we get a lot of patients that come in on anticoagulation for superficial thrombophlebitis, which means clot in the veins just under the skin, between the skin and the muscle. That is to be left alone. I mean, you can give them an aspirin or you can give them ibuprofen or nonsteroidals or whatnot, and warm compresses, but do not anticoagulate those patients in the absence of a deep venous thrombosis.
And Rob, there was a recent study which surprised me that showed that on top of anticoagulation, aspirin did seem to help reduce subsequent incidence of DVT, not superficial. Do you routinely or ever recommend aspirin on top of anticoagulation for DVT prevention in a person with a prior documented DVT?
My practice has not changed based on that study prophylactically yet, so I try to stay away from nonsteroidals and anticoagulation. If I read your question correctly, a person who has a DVT and is on
Already on anticoagulation.
I keep them anticoagulated, try to keep them away from the aspirin. The standard of care at least hasn't changed at this point, so interesting concept.
And then how long do you? Yeah, somebody had the idea, and I don't know the biology of it because it doesn't make sense to me, right? But that's what the data showed, is that there was an additional incremental reduction in recurrent DVT when you added aspirin on top of, and I believe the trial was warfarin. It wasn't.
Are you talking about recurrent DVT?
Yeah, undocumented DVT. So second question I have for you, Rob, how long do you continue in an unprovoked DVT with documented DVT? Now the person's been on 6 months of therapy, as an example, and now the ultrasound shows no residual thrombus. Do you take the person off anticoagulation, or do you commit them to lifetime anticoagulant therapy? What's your current approach?
Well, that's a good question because there is no correct answer. So an unprovoked DVT is somebody who shows up with a spontaneous, say, popliteal or deep venous thrombus. So the first thing you do is you want to anticoagulate them, and when do you take them off? We know that a provoked DVT from surgery, from a long airplane ride or crush injury or whatnot, is 3 to 6 months. The answer to that is every patient should be considered, and if they don't have cancer, if they don't have something identifiable, but an unprovoked DVT has a 7% chance of recurrent DVT per year. So if they're on a novel anticoagulant, in which intracranial bleed rate is significantly low, they're not really boxing or jumping out of airplanes or whatnot, I tend to keep them on it, but I do discuss with them that there is no yes or no answer as far as the duration of anticoagulation.
And do you do a hypercoagulable workup on those people?
I do. On every one of them. Unprovoked DVT gets the workup.
Yeah. Okay. A 67-year-old man comes in for a follow-up visit after being hospitalized with pneumonia and found to have paroxysmal atrial fibrillation. He was asymptomatic during these episodes. Before being discharged, he was put on apixaban and metoprolol, and his heart rate today is 96 beats per minute. What should his target heart rate be? Okay. Correct answer, less than 70. I'm sorry, the best choice you answered was less than 70.
Only true if they have systolic heart failure. So.
Only true if they...
Yeah.
The correct answer is less than 110. All right, this is from the published in the New England Journal of Medicine 2010, the RACE-2 study, where they looked at 2 treatment strategies. One was called the lenient control the heart rate less than 110, and one was strict control. Let's get the heart rate less than 80, and with exercise less than 110. And what they found after 3 years, that there were no differences, no adverse outcomes, no increase in hospitalizations, no CHF. So lenient control is as effective as strict control. We don't have to push for them to be on more drugs, more side effects. Again, one of those extremes. So you agree with this?
Yeah, I do, but with the caveats that A, they don't have heart failure, because then I do have stricter control, and B, they're not symptomatic. So in that trial, the people who felt okay at a heart rate of 110 versus 80, if somebody's at 110 in your office and they're complaining of wild palpitations, the flip side of the coin is, you just said it, you can safely push their heart rate slower, and there didn't seem to be a downside of doing so.
Correct. So, when patients are asymptomatic and permanent atrial fibrillation, that was key. Thanks for pointing it out. Okay. A 67-year-old man is seen for pre-op evaluation for hip surgery. He has no medical problems, take no medication, feels well, exercise daily for 45 to 60 minutes. He smoked for 16 years but quit 20 years ago. His physical examination, vitals, and EKG are all normal. Which of the following do you recommend? Okay, this is a repeat, so from a couple of years ago.
He's trying to see if you remember.
So the guy has a normal EKG, normal, is very active, really does not need a stress test, and you chose do nothing. And the correct answer is an abdominal ultrasound screening. Okay, one of the most neglected diseases, one of the most commonest missed diagnoses. Look at it when you compare it to breast cancer, prostate cancer, AIDS. And the current U.S. Preventative Task Force recommends that men 65 to 75 who ever smoked, ever, needs a one-time screening of an abdominal ultrasound to rule out an abdominal aortic aneurysm. This is a class 1 recommendation. So he had his ultrasound, and his ultrasound reveals a 3.4 centimeter abdominal aortic aneurysm. When should his next abdominal ultrasound be scheduled? Okay. 6 months and 1 year. And the correct answer? 3 years. Okay, let me tell you why. Abdominal ultrasounds grow at a rate of about 0.3 centimeters a year. So if somebody has an abdominal aneurysm of 3.4, next year you expect it to be 3.7. The year after that you expect it to be 4.0. The year after that you expect it to be 4.3. The year after that you expect it to be 4.6. So it grows at about 0.3 centimeters a year. And the recommendations are that if it's less than 3, which is almost normal, 5 years, less than 3.5, 3 years, less than 4.5, 1 year, and then more than 4.5 every 6 months. So you can see we don't have to, because it grows relatively slowly. Elective repair is recommended when it reaches about 5.5, or if it expands to more than 0.5 centimeters within a 6-year period. So 0.3 centimeters a year, that's a lot. 2.5 centimeters is an inch.
0.5 in 6 months.
0.5 in 6 months, yes. Now remember, if a patient has a life expectancy of less than 2 years, don't send them for an open repair. It's a major operation. Yes, sir.
So with that logic, if you have a person who smoked and they're 65 years old and you come in and you get that first time screening, and then you, like, what happens during the 2 years they have a normal scan at 65 years?
It's very small, because if it goes 0.3, but if they have, if you check it in 5 years, even let's say less than 3, if the abdominal aorta is ectatic, slightly dilated, you can check it in 5 years, but you don't need to do it
If it was
sooner
totally normal, Medicare will
Then
not pay for another one.
Right,
Yeah.
right. Normal won't. It's a one-time screening. Okay. A 63-year-old man complains of substernal chest discomfort provoked with moderate exertion, such as walking uphill to his mailbox. His symptoms occur almost daily. So he walks uphill, he has chest discomfort. Stress tests performed revealed a mild reversible ischemic defect. Cardiac catheterization revealed a focal 80% stenosis of the mid-LAD. No other significant disease present. You missing the question?
Yeah.
I had seen it.
We don't have it on
It's-
paper,
it's in
but
there.
it's
I
okay.
saw this one.
Oh, I'm sorry. I apologize. Okay, so basically a 63-year-old substernal chest discomfort with exertion, small ischemic defect, LAD has an 80% stenosis. This is, again, this question is from the American College of Cardiology Self-Assessment Program. Good, good. You can see he works in the cath lab.
Yeah.
Actually, at 80%, you don't need an FFR.
I can tell you that every cardiologist will say angioplasty and stenting. And the correct answer is prescribed metoprolol and sublingual nitroglycerin.
Yeah. So
It's a
Mo,
small defect. Small reversible. Where's that quality measures? You asked the question earlier. You want to get the patient's heart rate to about 55 to 60. That's 75% of the rate that causes angina. That's your first choice. So lower the heart rate, give the patient nitrates, see if the angina improves. And if the angina improves, you're home free. What do you think about this? I know I would, I'd probably send it.
Yeah, so going back a step, if the person had a small defect in our institute, we wouldn't even cath them. So we wouldn't be tempted to do a stent, because once you have the data, you're going to be tempted to do a stent.
Can I interrupt you and say, please repeat that? Because we get called by the hospitalists all the time, but there's a small, subtle, reversible defect.
Aggressive medical therapy is what is warranted for small defects. In my view, for example, they say nitroglycerin. Show me the data that nitroglycerin makes a whit of a difference in this disease. It doesn't make any difference. So what they should have said is put the guy on intensive lipid-lowering therapy and aspirin a day, and for symptom relief, metoprolol. That would have made more sense.
Well, I'm an interventionalist. If I see in a 63-year-old person who's quite young still, since I'm not far from that, and I have an 80% stenosis and I'm active, and how many times do we see 80% stenosis or significant stenosis by FFR that are missed by a scintigram study?
Yeah.
And so I'm not going to go by the size of that defect. If I see a type A lesion, meaning a simple stent to put in there, I'm going to fix it once and for all. With these medicated stents,
Well,
the risk
you
of
fix
thrombosis.
it, I don't know if it's for all. Maybe once.
I mean, either that or I'm going to the unemployment line.
Yeah, well, and what you said is, particularly if it were more proximal in the LAD and stuff, it's just the more distal, then, what are we treating? The oculostenotic reflex?
Yeah. But I'll tell you, I've been to board
little more than
reviews,
that.
cardiology board reviews, and the experts on the board reviews present questions like this, and they say all cardiologists will stent it. But the guidelines say medical management, especially if it's a small defect. Okay. The work group that developed... You guys are there?
We're here.
All right. Let me
Oh, there
let
it
you
is.
catch
Okay,
up.
we're there.
Okay. The work group that developed the recent ACC-AHA guidelines on assessment of cardiovascular risk considered a list of novel risk markers as optional screening tests when there is uncertainty regarding whether to initiate pharmacologic therapy. Which of the following novel markers is the only one to receive a Class 3 recommendation, meaning no benefit? This came up earlier in the talk today. Okay. C-reactive protein, carotid intima. Those that said carotid intima medial thickness were paying attention. So, what do you have to say to this, Rich? I mean, there were 9 novel risk factors looked at by the work group. ApoB was looked at, didn't get a nod. Carotid intima media thickness, they felt that it won't harm you to do it, but it doesn't reclassify the patient's risk. So there's really no benefit in doing it. The ABI we talked about, the calcium score, if it's elevated, we know the patient has plaque. It may be mild, may be moderate or severe, but they have underlying atherosclerotic disease. And the C-reactive protein, at least the way I use it, and I'll ask the panel for their opinion, if I have a patient, and that's what I always said, I used it as second opinion. It says here, as an option when you are uncertain whether to initiate treatment. So if you have somebody with a borderline LDL slightly elevated, you're not sure if you want to treat them, you do a C-reactive protein, it's more than 2, you lean towards putting them on a statin. Rich?
Yeah, I agree with that. And there's a reason, as much as people decry Medicare, there's a reason Medicare does not currently pay for CIMT. And this was revisited a week ago today in Chicago. And it's unlikely that CIMT will be paid for by Medicare in the future because the evidence just simply does not support that it will be decisive enough to make it valuable. All of the other three here would change your therapy, no question about it, right? So if you know somebody has coronary artery calcium, they have atherosclerosis. If they have atherosclerosis, you need to attend to their atherosclerosis. That's the bottom line.
Just a few more questions. We'll be done shortly, hopefully. Okay, I think Rich talked about that loop recorder, so I'll skip on that. This loop recorder that you see here, the small loop recorder, really literally. So if somebody has recurrent syncope or near syncope, it takes less than 2 minutes to put in a loop recorder under the skin, less than 2 minutes. Honestly, it's better than a 30-day event recorder. You put it under the skin, it's left in place for 3 years, and they have a monitored system at home, downloads the data every day, and if a patient has an arrhythmia, you can pick it up. And I had a patient after 7 months, had a syncopal episode, went to complete heart block, and the patient needed a pacemaker. So these loop recorders have become smaller, user-friendly, easy to implant. Okay. I'll briefly go on this. A 59-year-old is discharged after a recent MI. He was counseled about quitting smoking. Which of the following will most likely improve his long-term abstinence? Okay. All right. Evenly split there. Nicotine inhaler didn't get much. The correct answer is follow-up. Follow-up, just like heart failure patients. If you have a patient discharged and you ensure that they have a follow-up and follow them, they are less likely to be readmitted. Same thing, your follow-up to re-emphasize and stress the importance. If a smoker has a myocardial infarction and they quit smoking, within 2.5 to 3 years, their risk is that of a non-smoker. It's huge and very significant. That's why it's now a core measure as well. Okay.
Mo, can I ask you why 6 weeks? I mean, why not a week? I'm just asking.
I know. Heart failure, they say a week.
Yeah.
I don't know. I pulled it out of the
That's what they say, 6 weeks?
Yeah, that's what they say, 6 weeks. Okay, at what age should high school student athletes get an EKG prior to participating in sports? Okay. Routine EKGs are not recommended. Excellent. Routine EKGs are not recommended. Any time a high school athlete or college student dies, it generates a lot of media attention and reignites the debate about whether we should screen a high school student and college athletes. But the problem is there's no randomized clinical control trials. The risk of sudden cardiac death is very, very low. The task force to interpret these EKGs is not there. And also there's up to a 40% false positive. Can you imagine if you're a mother and you're told that the child has an abnormal EKG and that it provokes unnecessary tests and more tests and the concern and the worry forever? So the American Heart Association says it's not practical, nor prudent, nor recommended.
Although it does differ in the different parts of the world. So in Italy, the standard indeed is for all such athletes to have screening, and that's true in Portugal and other countries as well. So part of this is driven by the economics of this. I was on a committee where we were trying to come to grips with this, and depending on what number you plug in for how much does it cost to do an EKG, you come up with a different answer.
Yeah, my 2 cents is that anytime that I have a patient that's under 18 and they're asking me a favor if I'll see a pediatric age patient, it's because somebody got an EKG and there's absolutely nothing wrong with the patient. but they saw something they didn't like. So,
You know,
great question.
There should be AEDs. They should have a thorough physical. There's a sudden cardiac death physical for pediatric patients. All of those parents should go through, but not routinely recommended.
Yeah, and the biggest marker is if they fainted. If they have a previous history of fainting, that's huge and sometimes glossed over.
Yeah.
No, they use both in some. It depends. Depends on what. Also, there are firm data, for example, that you can enrich the population if you use certain sports. And so, for example, they looked at the golf team versus the football team. And if you look at the football team, it's a much higher likelihood of finding an abnormality, hypertrophic cardiomyopathy or long QT, than if you look at the golf team or the chess team. So they do both, and currently now all pro athletes are mandated at the camps to have echo and EKG. So at the NBA and the NFL level, they all get screening now.
All right, just a couple of more questions. A patient presents to your office complaining of general symptoms of lower extremity pain and discomfort at rest or after ambulation. Now, I brought this question up because so many patients come to the office, my legs feel heavy, my legs hurt, my legs swell. What would you say is the most common and likely etiology? All right. Musculoskeletal. And the correct answer? Venous insufficiency.
There's a reason I'm sitting.
That's right. I knew that was going to be the answer with Rob here.
No, I'm really, I see so many of these patients. I'm surprised when I read this question, so I thought it would be a good question. Rob, what do you think?
Yeah, well, just quickly, I'll take less than a minute here. Venous insufficiency is very common, number one, and you can talk about restless legs and cramps and burning and aching and so forth. And if I went into a change in my career to treat that, then that's a pretty dissatisfying move if that's all I'm taking care of. But the reality is that we see so many patients that are mistreated. The diagnosis, this is the big impersonator. We have people on 40 BID of Lasix. They have no pulmonary tricuspid regurgitation, no hypovolemia, no renal disease, but they're on Lasix and potassium. We've even had some people that have coded before because they're diuresed. We have so many people that are on Cymbalta and Lyrica and gabapentin, and these drugs are not trivial. My little sister's on Lyrica, and she's nutty every time she takes one pill. So some of these people are chronically on it because of a, quote, neuropathy that has nothing to do with a neuropathy because they have no diabetes or other reasons. We have people on steroid creams and trips to dermatologists and all these kind of things, and there's a lot of them. And we touched on the incidence and the prevalence and so forth, 30 million Americans. And most of these patients complain. Many of them are on non-steroidals, on a ton of medications. I've covered just a few of them. But they're basically being mistreated. The real diagnosis is venous insufficiency. I have never seen patients, short of the one that codes and drops dead, and you bring them back, you stent them, and do all kinds of stuff. Now they're, riding a bike or alive. Obviously, they're going to be very, very appreciative. But in general, percentage-wise, the patients that we treat, the happiest patients are the venous insufficiency patients, not because it's a heart attack or a stroke, but because they've lived 20, 30, 40 years with the symptoms, and every time they go see a care practitioner, they say, oh, don't worry about that. Oh, it's no big deal. It's just, cosmetic and this and that. So my point is it's very, very common. It's very often mistreated. It's easily treated with a venous ultrasound, and we're trying to get the word out. I mean, this is a great question, Mo.
So let me ask you. I had a motor vehicle accident about 8 months ago.
Yes,
and
you did.
The swelling, I'm lucky to be here, so the swelling in my right ankle and leg just won't go away. If I don't wear a compression stocking in 2 hours, I'm having a lot of discomfort. Venous insufficiency play a role?
It could. A number of things happen. You suffered fracture and dislocation, if I recall. So the most common thing is edema and scarring that will cause venous insufficiency, but localized. You may have a perforator, which is a communication. You all have a deep venous system and a superficial system. All of it drains into the deep and takes off. but there are perforators at the level of the ankle and different places, and you may have a perforator that's leaking back from the deep into the superficial tissue, and it would involve getting an ultrasound and taking a look at it.
So from the trauma, a leak from the trauma?
The perforator was already there, but because you scarred in the trauma, you can have a fracture of the valves in the perforator, and now you have wide open reflux into the ankle.
Okay. And, you know,
You need to see
I'm
Rob.
terrible
We
at
take all
Venus, and
insurance,
that's why
Buzz.
when I had these questions.
We'll take your insurance.
Is he insured?
Okay. I don't have insurance. All right, I think this is our last question. A 48-year-old man is discharged. Now, you got to get this right, guys. This was they pounded this in the earlier today. A 48-year-old man is discharged from the hospital following an acute anterior myocardial infarction and stenting of his LAD. He's on the following medication: aspirin, clopidogrel, amlodipine, losartan, hydrochlorothiazide, Crestor. He takes all of his medication in the morning. Which of the following do you recommend? All right. Correct answer is advised that he take his losartan at night. You guys were paying attention because I thought most of you would say take his statin at night. But, you know, the statins, if you take most of the statins, they have a very short half-life of only 6 hours. And we know that that cholesterol biosynthesis is greatest at night. So if you take your statin at night, you're going to get greater reductions in your LDL than if you take your statin in the morning. Now, rosuvastatin or Crestor has a half-life of 19 hours, and atorvastatin or Lipitor has a half-life of 14 hours. So those two statins have a very long half-life, a very slow metabolism, and those two statins can be taken at any time. So Crestor and Lipitor can be taken at any time, but the other statins should be taken at night. Rich, you want to just quickly talk about
I would
the
agree with
importance
your
of the blood pressure also?
Yeah, so the blood pressure, part of the issue was raised by Chris that the blood pressure rises in the morning. But there's another interesting facet here. It turns out that the left ventricle hypertrophies while you're sleeping. Okay, so they've done these chronobiology to see when does the LV thicken. And it's actually when you're sleeping and resting, that's when the LV changes its biology. So one of the concepts is if you give the antihypertensives at bedtime, you'll negate some of the LVH that we know is not only a producer of heart failure, but a marker of adverse prognosis as well. So that's another reason to take it at night.
Great. Well, please, these monitors were rented, these answer response, so please make sure you leave it on the table and we'll pick it up. Thank you all for attending. Great education. Your CME certificates will be available. Thanks for
Always
staying,
great.
man.
Always great. You did a good
Great,
job.
man. Thanks for staying. You know,
No problem.
made it really nice that you could